وعلى بركة الله هنبدأ إن شاء الله. The first symposium is really a very interesting one, which is basic intraocular oncology.
Thank you very much, my dear friend, brother and colleague, Dr. Ahmed Mostafa, for inviting the Ocular Oncology Group at Kasr Aini to present this symposium. For a long time, intraocular tumors has been a dark field or a subspecialty that's not explored too much and did not arouse too much interest, maybe because of logistics of treatment, which are difficult, and the difficult setup. Recently, we have done this complete setup at Cairo University Hospital, Kasr Aini, and this offers the service free of charge. I could not do this alone, but I have a distinguished group of colleagues, Dr. Dina, Yusuf, and Abdesalam, who are members of this team and are going to present this symposium with me today. The first talk would be by Dr. Dina Hossein, Assistant Professor at Cairo University, about Retinoblastoma diagnosis and management update.
Thank you, Dr. Hani, and good morning, everyone. My talk will be on the diagnosis and management update of retinoblastoma, which is the which is the most common intraocular tumor in children and the second most common intraocular malignancy in general after choroidal melanoma. 90% of cases present before 4 years of age, and the mean age at diagnosis is earliest in familial cases, around 4 months. It's around 1 year in bilateral disease and 2 years in unilateral disease. Without going into details of the inheritance, we have to know that the retinoblastoma gene is a tumor suppressor recessive gene, and the presence of one functional allele prevents the malignant transformation. This explains the risk of bilaterality, multifocality, and the risk of second malignancies in the hereditary form and the early age of presentation, unlike the non-hereditary form in which the two mutations occur after conceptions, and this is why it tends to present with a unilateral disease and at a later onset. Most of the cases present with either leukocoria or strabismus, like this boy who presented primarily to Abu Rish Strabismus Clinic. And when the flat retinoblastoma is present, it tends to present as a masquerade syndrome sometimes, like the second picture, in which the child was referred actually to our uveitis clinic. And when the tumor outgrows its blood supply and becomes necrotic, it might present as an orbital cellulitis-like picture. Other atypical presentations with more advanced disease include secondary glaucoma or spontaneous hyphema. Whenever we have the definite or the probable clinical diagnosis of a retinoblastoma, the most two important investigations to be performed are the ultrasound and the MRI. The ultrasound determines the extent and the size of the tumor. Accurate measurements of the base and height of the tumor and any associated detachment or vitreous seeding is detected. And it's very important in the MRI to exclude the trilateral retinoblastoma with the pineal body involvement and to comment on any optic nerve head infiltration or extraocular extension. The pathognomonic sign of retinoblastoma is the calcification, although it might not be present in some cases, making the diagnosis a bit challenging. Bone marrow examination or lumbar puncture is performed if there is concern regarding the CSF or bone marrow spread, but it's not routinely done. And the CT is avoided because of the possible genetic cancer syndrome, especially in cases where a hereditary form of the disease is suspected. The management goals, they have to be very clear. Our first goal is to preserve the life of this child. It comes next, the priority of salvaging the globe, and then to maximize the vision. Minimizing also the side effects and complications of treatment in those young children is also important. And we have three main treatment modalities: the local, or what's referred to as the focal consolidation therapy, mainly the laser, the cryotherapy, the thermotherapy, and the recent brachytherapy. The second group is the enucleation or the surgery group and the chemotherapy. The international classification for intraocular retinoblastoma is one of the most important classifications because most recent treatment protocols are based on this classification. It classifies the tumor into 5 groups from A to E. Group A includes small tumors. They are away from the foveola or the disc, and they have the best prognosis. Group B, when the tumor exceeds 3 millimeter and have a macular or juxtapapillary location. Group C are tumors in which vitreous or subretinal seeds start to appear, but still confined to the tumor. If it becomes extensive, this is a group D disease, and the most advanced is group E, in which the extensive retinoblastoma occupies most of the globe, or there are complications like neovascular glaucoma or infiltration of the iris or ciliary body. Traditional treatment was enucleation for unilateral cases. For bilateral cases, enucleation for the most advanced side and external beam radiotherapy for the other, and systemic chemotherapy for the metastatic retinoblastoma. This is no longer the case nowadays because treatment strategies have evolved over the past few decades with a trend towards globe salvage. And the first game changer was the appearance of the chemotherapy in the 90s. They discovered that the retinoblastoma is a very chemosensitive malignancy, and the preferred treatment modality shifted then from external beam radiotherapy to chemotherapy, and the enucleation rates dropped markedly, up to 65% in unilateral cases from 95% in the external beam radiotherapy era, and up to 2% in bilateral cases. But still, the systemic chemotherapy-related toxicities remained a major concern, and they can be fatal sometimes in young infants. So in 2008, the selective intra-ophthalmic artery injection of melphalan was reported using a transfemoral microcatheter to achieve a targeted focal delivery of a high-dose chemotherapy to the tumor with minimal systemic absorption and systemic complications and more efficacy. And since then, the technique has been adopted in most of the centers worldwide and in ours as well. And the term targeted chemotherapy was then used. And initially, it was used as a salvage treatment for eyes not responding to the systemic chemotherapy, but currently it's the first-line treatment when focal consolidation treatment is possible. The minimum age usually for successful cannulation is 3 months, and we use a combination of a melphalan and another very potent chemotherapeutic agents called topotecan. Still, control of vitreous seeds remained one of the most challenging aspects because they're resistant to both the systemic and the intraarterial chemotherapy. But with the introduction of the intravitreal transconjunctival pars plana injection of melphalan with cryotherapy at the injection site, control of the vitreous and subretinal seeding could be achieved in nearly 100% of cases. This is an example of a stage D girl who presented to us, and this was 1 month after the intraarterial chemotherapy with considerable shrinkage and regression of the tumor. And this is another one after intravitreal injection with significant clearance of the vitreous seed as seen here by the ultrasonography. The second game changer is the radioactive plugs, in which the radioactive seeds, we use the ruthenium 106, are placed on one side of a thin plate of metal, which is called a plug, and delivers a constant high dose of the radiation transclear. So it's a form of a targeted radiotherapy. It's usually left in place for a few days to deliver a 50 gray dose to the tumor apex, and then requires a second surgical procedure for removal. These are the sizes of the plugs we have, and we use them based on the size of the base of the tumor. We use it if we have a solitary lesion, 15 millimeter or less in diameter and 10 millimeter or less in thickness. Sometimes if we have 2 lesions which are small or close enough to be covered by one plaque, it can be used as well. The key is the proper localization of the tumor with the plaque covering the basal diameter. And it's kept in place using 6-0 vicryl retention sutures. So today, the targeted chemotherapy is administered to shrink the tumor, and it's referred to chemo reduction to allow the subsequent treatment with focal consolidative therapy, either the laser, the thermotherapy, or the cryotherapy, depending on the site of the tumor. This is in small tumors, or the plaque radiotherapy for medium-sized tumors. For group A tumors, the focal consolidation therapy alone can be effective sometimes. Still, the enucleation has its place in large unilateral tumors, especially for eyes with no visual potential, in advanced group D or E tumors, and if there's progression despite the conservative treatments, and the child must be monitored closely even after enucleation for the orbital relapse in the first 2 years after surgery. We have 4 main types of regression. The first one, or type 1, is the most one we encounter, is the calcified or the cottage cheese tumor. And this is a picture of a girl after we performed the brachytherapy for her. Type 2, it's the most challenging because sometimes you can differentiate between it and the active tumor. Type 3 is a combination of both. And the type 4 is the atrophic tumor regression into a chorioretinal atrophic scar. We have to follow up those children very closely under anesthesia with dilated fundus examination and indentation every 2 to 3 months in the first year, and then up to school age. This is the last slide to simplify a very simplified management protocol for unilateral cases. Group A, focal treatments could be successful. If any progression, we resort to the chemo and the brachytherapy. In group B and C, chemotherapy or chemo reduction followed by consolidation treatment. And in group D, these are the cases which usually require the intra-arterial chemotherapy. Most of group E require enucleation with or without adjuvant systemic chemotherapy, depending on their high-risk criteria, documented pathologically or histopathologically. I would like to thank the whole team, especially Dr. Hani Hamza, and thank you very much.
Thank you very much, Dr. Dina, for this nice overview for the update of treatment for retinoblastoma. The next talk would be by Dr. Yusuf Helmi about differential diagnosis of an iris mass. Dr. Yusuf, please.
So we'll be discussing a differential diagnosis for an iris mass. So when presented with an iris mass, it sometimes seems confusing. Is this malignant? Is this benign? So we're going to present a simplified approach to try and reach a diagnosis. So first of all, we ask ourselves, is the mass stromal or epithelial? And if it's epithelial, is it the pure iris mass or is it iridociliary? The next question, is it pigmented or non-pigmented? And finally, are there any special characters? Is it solid or cystic? Is there hyphema, glaucoma, or chorictopia? So just a quick reminder, the iris stroma is on the posterior aspect of the iris, on the anterior aspect of the iris, and the iris epithelium is on the posterior aspect. So when we're asking, is it stromal or epithelial, what we're basically asking is, can you see the mass coming from the front or from the back of the iris? If it's coming from the front of the iris, then this is a stromal iris mass. If it's coming from the back, then it's either an iridociliary mass, and at this point a UBM is required. If it's a pure iris mass, then it's coming from the epithelium of the iris. And this is a pathological or a histopathological differentiation. So for stromal iris masses arising from the front of the iris, the next question is it pigmented or non-pigmented? And for a pigmented stromal iris mass, we're thinking of melanocytic lesions, freckles, nevi, melanocytomas, Lisch nodules, and of course the ever scary melanoma. So for freckles, nevi, and melanocytoma, these are benign tumors. The differences lie, they're all stromal in origin, and the differences lie in the level of pigmentation. A freckle is the most superficial. A nevus shows deeper penetration of the iris stroma, like the photo in the center here. And the melanocytoma is a subset of iris nevi, which is darker and has a mound of black sand appearance. Most cases remain stable and require no intervention. However, spontaneous necrosis with consequent secondary glaucoma can occur. Lisch nodules are a subset of nevi that occur most commonly in cutaneous neurofibromatosis, and they are all benign tumors as well. And most importantly, of course, is the primary malignant neoplasm arising from the melanocytes of the iris stroma, the melanoma. It's actually purely iris in only 4% of cases. So when you see an iris mass that's pigmented and you're considering a melanoma, a UBM and an ultrasound and a good fundus examination is required because it might also have a ciliary body component. So Shields and their team created a lettering guide to remember the risk factors predictive of iris nevus growth to melanoma, A, B, C, D, E, and F. So older age, the presence of hyphema, blood, C, the number of clock hours inferiorly, and this is an important sign because melanoma is more common in the inferior half of the iris. D, which is the diffuse configuration, ectropion E, and a feathery margin F. These key clinical features help to identify iris melanoma from an iris nevus. In a very large series of 8,000 patients with pigmented iris masses proven to be melanoma, 90% of cases were pigmented, 45% were inferior and had choroidopia, 35% had secondary glaucoma, and then we had some other signs like seeding into the AC and the angle, ectropion UV, with only 3% presenting with hyphema or extraocular extension. The treatment options for a melanoma of the iris include either resection, if it's only including less than 4 clock hours of the iris, and there are no seeds. If we have seeds, or it's extending more than 4 clock hours within the iris, then plaque radiotherapy, like Dr. Dina Hassan just showed, is a viable option. The plaque is placed on the limbus, straddling the cornea, and for a massive iris mass with glaucoma and absolute eye, then at this point we consider enucleation. What about a non-pigmented solid stromal mass? So if it's non-pigmented, we have to remember first, before jumping to the metastases and other less important tumors, the amelanotic melanoma. So if you remember from Shields' case, 90% of cases were pigmented, which means that 10% of melanoma are actually amelanotic. So we just keep this in mind when we're looking at a non-pigmented iris stromal mass. Also quite important are iris metastases. Now, the iris receives metastases from all over the body. The most reports in the literature include primary pulmonary malignancies. This here was a small cell carcinoma of the lung that metastasized to the upper half of the iris. And you can see it's a non-pigmented iris mass causing a pupillary distortion, and it shows some vascularity. This is a renal cell carcinoma, and in the first image here you can see the extent of the mass, and after systemic chemotherapy for the primary, the mass actually shrunk in size. These are, of course, are images from the literature, not our images. And finally, this is a patient who presented with a breast cancer and metastasized to the iris with this appearance here after the completion of external beam radiotherapy. Other non-pigmented masses include vascular tumors of the iris. This was another report by Shields and their team, and they differentiated vascular tumors of the iris into racemose, capillary and cavernous hemangiomas, varices, and microhemangiomatosis. So the racemose hemangioma is an abnormal communication between artery and vein. It can be simple with a single tortuous vessel, or complex with a sessile vascular mass formed by intertwining vessels. Sometimes there is a sentinel vessel visible in the limbal sclera at the entry point of the hemangioma in the iris root. Usually, these hemangiomas don't require intervention. Hyphema is a very rare complication. Microhemangiomatosis look like new vessels on the iris in non-diabetic patients, and they usually leak fluorescein into the aqueous humor. Varices, and these are dilated, elongated vessels, they show hypofluorescence on fluorescein angiography, and they sometimes present with hyphema. These are very, very rare tumors. Cavernous hemangiomas, multiple thin wall dilated vascular channels lined by normal endothelial cells with surface gliosis. And sometimes the patients have other hemangiomata in the kidney, in the liver, and in the skin. Extremely rare capillary hemangioma of the iris, and this is actually one report in the literature about a child who had cutaneous capillary hemangioma and also had an iris capillary hemangioma and did not really require management. It was just reported in the literature. What about choristomas of the iris? A choristoma is an accumulation of disorganized benign tissue in an abnormal location. And the iris has been reported to be the site of lacrimal choristomas. So you have lacrimal tissue in the iris. So how did we get lacrimal tissue in the iris? Because the optic cup closes before lacrimal tissue develops. This means that you're not supposed to have lacrimal tissue in the iris. And there are some theories, either that these lacrimal cells that were destined to become lacrimal cells were implanted apparently early, or during formation of the lens, surface epithelium was implanted or pinched off. It may also occur that intraocular extension of lacrimal tissue along pre-existing scleral defects in utero. And finally, it might be a form of metaplasia with apparent differentiation of embryonic intraocular tissue rather than implantation. Also in the literature, very few reports, but this here was a fleshy salmon-colored mass, and it was resected, of course, because they thought it was malignant, and they found these tubular acini of lacrimal cells, and actually it grows in size because it fills with tears. So this is actually an interesting mass, and usually these diagnoses are made post-inoculation. Another interesting mass is the xanthogranuloma. Juvenile xanthogranulomatosis is a rare cutaneous disorder, and tumors are infiltrated by histiocytes with Teuton giant cells. Clinically, they present with these fleshy pink-shaped masses in the angle and the anterior stroma, and usually they confuse with retinoblastoma or amelanotic melanoma. The criteria to diagnose a xanthogranuloma is spontaneous in a child, spontaneous hyphema, red eye with signs of uveitis, congenital or acquired heterochromia iridis, iris masses, and unilateral glaucoma. Very, very rare also masses include the leiomyoma, which is a smooth muscle mass, probably diagnosed after inoculation with the suspicion of a metastasis. If the mass is cystic, then we're considering it might be a melanoma and it's cystic. It also might be a primary iris cyst, and this occurs in children and usually presents with secondary glaucoma, photophobia, and pain. It can be aspirated actually and collapsed without excision. Remember also that we can have a secondary iris stromal cyst secondary to trauma. What about masses from the back of the iris without ciliary body involvement? These are epithelial iris masses, including iris epithelial solid tumors like iris pigment epithelial adenoma, medulloepithelioma, and adenocarcinoma. These tumors arise from the iris epithelium on the back surface of the iris, and they cause thinning or complete effacement of the overlying iris stroma, and they typically block light with transillumination. The medulloepithelioma is an important epithelial mass which arises from the primitive medullary epithelium and is diagnosed at the age of 5. So it presents in children with pain, leukocoria, and photophobia. The commonest sign is the presence of a mass in the iris of the ciliary body, glaucoma, and cataract. There are two types according to the differentiation into teratoid or non-teratoid, according to the presence of elements like hyaline cartilage, rhabdomyoblasts, and differentiated mesenchymal cells. And it can be benign or malignant according to the presence of sarcomatous changes, pleomorphism, mitotic activity, or spread. Medulloepithelioma is treated mainly by enucleation. However, it can also receive plaque radiotherapy or excision. For a cystic mass, and we're about to finish, for cystic masses we have the primary epithelial cysts, and these are benign cysts arising from the back surface of the iris. They can also detach from the iris and float freely in the anterior chamber, and secondary iris cysts which are drug-induced, usually to prostaglandin analogs. Not to confuse everyone, but we need to also remember that we have non-neoplastic simulators of iris masses, but these are more easy to diagnose. And in a nutshell, when you're presented with an iris mass, look at where it's arising from. If it's arising from the stroma, if it's pigmented and there's correctopia, glaucoma, or hyphema, then usually consider it to be a melanoma until proven otherwise. Remember, metastasis, of course, this is very important, can be pigmented or non-pigmented. It's a solid mass and arises also from the stroma. Thank you very much.
Thank you very much, Dr. Youssef, for this interesting talk about iris masses, which are also a common clinical presentation that may be confusing. And the next talk I will present about the differential diagnosis of common fundus masses. Okay, I think any one of us has confronted this situation in his clinic, that he has a patient with a fundus mass and it's a confusing situation for him. He's asking himself, what's this lesion? Is it a nevus, melanoma, or another lesion? What should I do next to reach a diagnosis? If it is benign, can it turn malignant? And if it is a non-neoplastic lesion from the beginning, is this even an existing possibility that this is simply a non-tumor lesion? So typical choroidal nevi, as defined by the COM study, are melanocytic lesions with the greatest diameter of at least 5 millimeters or less in height and 1 millimeter or less in thickness. Usually they have a slate gray or brown color and with minimal thickness and ill-defined margins. Classic choroidal nevi affect 7% of the white population. They are usually pigmented with drusen overlying, RPE atrophy, and CNV. And drusen, RPE atrophy, and CNV are usually signs that this lesion is a benign lesion and has been there for a long time. So this is a good sign. Atypical nevi may be amelanotic, as we see in this case, and they are called blonde nevi. The main differential diagnosis of these lesions is from choroidal metastasis, and sometimes these lesions are surrounded by a white halo, as you can see in the lower image here. And this white halo is actually a good sign. They are called halo nevi, and they are 7 times less likely to transform into a malignant melanoma. What are the diagnostic clinical features of malignant melanoma? That the patient is symptomatic. Usually it's a dome-shaped or mushroom-shaped with a diffuse configuration, has variable pigmentation, posterior extension in many cases, abnormal RPE over the tumor. There may be an extraocular extension as well as glaucoma and inflammation in advanced cases. Now, there are some questions when you see a patient with a fundus lesion. If it is a nevus, do features of nevi change over time? Can nevus affect vision? Again, the answer is yes. Can a nevus grow and enlarge over time? Again, the answer is yes. And what is the risk of malignant transformation? It is 1 to 8,800. That's the incidence or the ratio of transformation. The change of nevi over time, they can change in thickness, they can change in the presence of drusen, and in their number over time, as you can see in these cases. Now, can nevi affect vision? Yes, extrafoveal nevi rarely affect vision, only in 2% of cases. But subfoveal nevi have a 26% chance of loss of vision of 3 or more lines in 20 years. What are the causes of visual loss? A subfoveal location of the tumor, compressing the photoreceptors, the presence of orange pigment, RPE detachment, foveal edema, and the development of CNV. Can a nevus grow and still remain a nevus? As we all know, growth is an indicator for transformation of melanoma, but growth is not an unequivocal indicator of malignancy. Some nevi can get slightly bigger over time, but these are extended periods of time, as these examples. We have this case in the upper part. This nevus has grown 2 millimeters over 7 years, and it still remains a nevus. Again, this one in 8 years has grown 1.5 millimeters only, so it still is a nevus. But look at this last example. Over 2 years, it has grown 4.5 millimeters. This is no longer a nevus, this is a melanoma. What are the risk factors for malignant transformation? The risk has been calculated, as we said, into 1 every 8,800 cases, according to Aaron Singh. These are low-risk nevi that are away from the posterior pole with overlying drusen, okay? But these are high-risk nevi that are close to the optic disc or macula with overlying orange pigment and some presence of subretinal fluid. Shields have developed a mnemonic in 2019, which is TEFSAM-DIM, to show the risk of transformation using multimodal imaging. And in this case, they indicated that a thickness of over 2 millimeters by ultrasonography, the presence of subretinal fluid on OCT, S stands for symptoms and vision less than 20/50, O for ocular stands for the presence of orange pigment, and this is detected by autofluorescence. The M in melanoma stands for acoustic hollowness on ultrasonography. And finally, DIM stands for diameter, which is more than 5 millimeters on color fundus photography. So any melanoma with any fundus lesion that is suspected and has these criteria has a very high risk of transformation. Now, the investigations we do are OCT, ultrasonography, autofluorescence, fluorescein angiography, and you can also expand the scope to do systemic imaging like PET-CT if you suspect a metastasis or so. In OCT, usually this is suitable for lesions that are less than 2 millimeters in thickness and 8 millimeters in base, less pigmented in younger patients and posterior pole tumors. So the picture of a choroidal nevus has a smooth mound, as we can see, with compression of the choriocapillaries above it, and usually there is no subretinal fluid.
while in melanoma you have a subretinal fluid and shaggy photoreceptors, as you can see. Autofluorescence is a very important sign to detect actually the presence of orange pigment in these lesions, which is a risk factor, as we all know. And ultrasonography has its criteria of tumor thickness, internal reflectivity, extrascleral extension, documented growth by measuring the lesion serially, and finally the acoustic hollowness and the choroidal excavation. Early detection is important to allow for early treatment using plugs or other conservative treatment. Now I'm going to go briefly over simulating lesions that may confuse with melanoma. This is an 80-year-old male presenting with this yellow fibrous tissue resulting from a prior hemorrhage and the dark fundus mass. You can see the heterogeneous color and the components of the lesion, and on ultrasonography it has a high echogenicity. This is actually a resolving hemorrhagic disciform lesion simulating melanoma. Again, this is another patient who has a large lesion with yellow circinate exudate around it, extramacular in the periphery. Now, this patient has drusen and dry atrophic AMD, but there is an entity called peripheral exudative hemorrhagic chorioretinopathy, which is exactly similar to CNV, developing in the peripheral retina. And the key factor here to diagnose this case is the presence of yellow exudate, which is not a feature at all in cases of melanoma. This is a patient presenting with a dark fundus mass, and this is actually a large subretinal hemorrhage from a macroaneurysm that has ruptured, and the fluorescein angiography can reveal it, and it can confuse clinically with a melanoma because of the dark color and the elevated lesion. Sometimes you have a gray lesion in the posterior pole like this, and when you do a fluorescein angiography, you find that it's actually a CNV, and it is perfused with abnormal vessels. It's a choroidal neovascular membrane. Another patient who had cataract surgery 3 weeks earlier, and upon examination of the fundus post-operative, the surgeon found this lesion in the upper part of the retina. By ultrasonography, the mass has a medium homogeneous internal reflectivity, and the pattern was quite similar to the melanoma. Late, but however, you can find these choroidal folds, which are not a feature of melanoma. Same lesion after 2 months, you can find a marked regression. If you find the regressing lesion, this is not a malignant melanoma. The melanomas grow progressively. So this was actually a choroidal hemorrhage at the time of cataract surgery that has resolved. Again, this is a patient who has this dark lesion, which is present on up gaze with irregular borders, and when the patient looks down, it disappears. What is this? This is actually a varix of the vortex vein that empties upon downward gaze, and upon upward gaze it gets compressed and congested and gives this dark fundus mass. Again, this patient has a peripheral lesion like this that simulates a melanoma, but ultrasonography shows that it has a very low internal reflectivity with fluid inside. So the fluid is not typical of choroidal, not tissue, this is fluid, not tissue, and typical of choroidal detachment, and this is part of the idiopathic uveal effusion syndrome. This is a female with a past history of breast cancer, so you have this lesion after 7 years from surgery, and actually 5 years from surgery, and this is a choroidal metastasis from breast cancer. Features of choroidal metastasis is that they are creamy in color, tend to grow on the flat, they do not tend to become high as melanoma, with exudative detachment, medium to high reflectivity, and on OCT they have a typical lumpy, bumpy appearance. This is a case of choroidal hemangioma in a female, which typically appears in females between the 2nd to 4th decades of life, located in the posterior pole, usually less than 6 millimeters in height, no feeder vessels, and on ICG angiography, they empty on the late phase. This is the last slide, and this is a patient with a dark fundus mass with clear lacunae inside, and actually this is Sherpy or congenital hypertrophy of the retinal pigment epithelium. And these patients may develop colonic cancer, and therefore they should have a colonoscopy on regular basis. Sometimes these are the multifocal congenital hypertrophy of the RPE. This is called bear tracks, and if they are not pigmented, they are called the polar bear tracks, and they should not be confused with a neoplastic lesion. Thank you very much.
Thank you, Dr. Hani, for this very interesting presentation. Next is Dr. Abdessalem Mohsen, and he'll talk about the management of uveal melanoma.
Good morning, everybody. Management of uveal melanoma. Uveal melanoma is the most common primary intraocular malignant tumor. 80 to 90% arise from the posterior uvea, while 10 to 20% from the anterior uvea. The management differs according to the tumor size, and according to the collaborative ocular melanoma study, they classify the tumors into small, medium, and large. Small, less than 3 millimeters height, medium, 3 to 5 millimeters height, and large, more than 5 millimeters in height. Also, the management differs according to the tumor site, anterior versus posterior, and its size in relation to the disc and the macula. Our main priority in management is to save life, then save eye, then save vision. Our two main lines of treatment in uveal melanoma is either inoculation or external beam radiation, which will be done to half of the globe. But in order to preserve the eye and vision, efforts were made to limit the radiation to the tumor, hence decreasing the collateral damage and preserving vision. We use the ionizing radiation. Ionizing radiation causes the double-stranded DNA break, affecting the rapidly proliferating tumor cells. They release either X-ray, alpha rays, beta, or gamma. The X-ray, which is used in the external beam radiation, cannot be focused on the tumor only. Thus, it causes a huge collateral damage and visual loss. The alpha rays have a very weak penetration, cannot be used in treatment, so we are left with the beta and gamma rays. So we want a material that can be placed, that emits beta or gamma and can be placed close to the tumor, thus irradiating the tumor with low collateral damage. And this is the brachytherapy. Brachytherapy is an episcleral plug containing the radioactive isotope, either iodine-125 emitting gamma rays or ruthenium-106 emitting beta rays. These have different size and different shapes for peripheral tumors, tumors close to the optic nerve, and cellular body tumors and tumors close to the iris. The tumors is localized by transillumination. Then the plug is sutured in place, covering the tumor with 2 millimeter safety margin. This graph shows that the radiation dose at the apex decreases as the tumor is more high. So at the scleral surface, the radiation is maximum and decreases as the tumor is larger. We want a recommended tumoricidal dose at the tumor apex of 70 to 100 grays. This is achieved at a height of 6 millimeter with the ruthenium plug and 9 millimeter with the iodine plug. So, our indication for brachytherapy is a tumor with less than 9 millimeter in thickness and basal diameter of 16 millimeter or less. And we achieved a 10-year survival rate similar to inoculation according to the collaborative ocular melanoma study. This is a choroidal melanoma which shows a marked atrophy after brachytherapy. So we are left with the larger tumors. The larger tumors, the only solution is inoculation. But if there is any role for radiation in the large tumors, the problem is to irradiate large tumor and excess rays are delivered to the eye, causing severe damage. But we find that the protons have the ability of localized dose distribution with sharp reduction of the dose outside the treated area, hence the proton beam therapy. The proton beam therapy has the ability to modulate the beam energy to cover the tumor at any depth, with sharp reduction of the dose outside the treated area. This is a large choroidal melanoma which shows marked reduction in size after proton beam therapy. The local control is achieved in almost all cases with the proton beam therapy. However, it is limited by the available center that contains or provide the proton beam therapy. Then we thought that instead of irradiating the tumor from one direction, we want to irradiate the tumor from multiple beams, focusing on the tumor simultaneous from different directions. and hence the stereotactic radiosurgery. Gamma knife is one of its examples. It delivers a high dose of radiation to the tumor with a small dose to the healthy tissue. And this is an example of a huge choroidal melanoma which shows marked decrease in size after stereotactic radiosurgery. Regarding the small tumors, according to the collaborative ocular melanoma study, small tumors are to be observed for growth, except if there is high risk factors. The high risk factors were modified recently according to the multimodal imaging, and it is thickness more than 2 millimeters by ultrasounds, fluid, subretinal fluid by OCT, symptoms, visual loss, orange pigment by autofluorescence, melanoma hollowness by ultrasounds, and diameter more than 5 millimeters by color photo. Small tumors, small posterior tumors can be treated by transpupillary thermotherapy, in which the tumor is heated for about 1 minute by 3 millimeters diode laser beams. Also, the transpupillary thermotherapy can be combined with brachytherapy to enhance the tumor control, and also after radiotherapy to decrease the tumor exudation, and in treatment of small recurrences after brachytherapy. And this is an example of small posterior choroidal melanoma, which shows marked atrophy after TTT. Surgical resection, either endoresection or transsurgical resection, will be discussed by Professor Dr. Hani Hamza in the next session. The new therapy. There are several new therapies for treatment of choroidal melanomas. The most promising is the AU011 nanoparticle therapy, in which the virus-like particle is conjugated with a photosensitizer material injected intravitreal. The material diffuses through the tissue to reach the melanoma, leading to pharmacological levels in the choroid. Then a laser of 690 nanometer wavelength leads to activation of the drug locally with a minimal collateral damage, and phase 3 started with the promising results. So to sum up, small tumors can be observed or treated with TTT, medium-sized brachytherapy is the gold standard, and large tumor inoculation or proton beam therapy if available, and resection do have a role. So the management depends mainly on the early detection of the tumor staging according to the site and the size, choosing the appropriate treatment, and long-term follow-up to enable timely management of any complication. Thank you for attention.
Thank you, Dr. Abdelsalam, for this comprehensive presentation. And the last presentation by Professor Dr. Hani Hamza, the surgical melanoma resection.
Thank you very much, Dina. Okay. Should I start? Okay, مش بتحرك ليه؟ Okay. I think Abdelsalam just covered this topic about the size of the tumor, whether it's small, medium, or large, according to the COM study. And the choice of treatment modality depends on several factors. Location of the tumor. A posterior tumor with a juxtapapillary location, which is a risk factor, can be treated by a plaque or endoresection, and usually with worse vision if it is close to the macula, while anterior tumors can be treated by external resection, which is an option, although it's quite a difficult surgery, as we will see. Surgical resection of any melanoma can be external or endoresection. External resection is indicated for anterior tumors, ciliocoroidal or iridociliary melanomas. And these tumors should be unsuitable for radiotherapy because radiotherapy, even with its complications, is safer than surgery. At the end of the surgery, a plaque is placed on the tumor base to treat any residual intrascleral cells and reduce the incidence of recurrence. So this patient is a female patient who presented several years ago, maybe 5 years ago, with a large tumor in the upper half of the retina, and it was a choroidal tumor in the anterior part. You see, we start by localizing the tumor by transillumination, and then we do a lamellar scleral dissection, which was deep in one part. This is outside of the tumor. And after you do the lamellar dissection, you start cutting the deep sclera with blunt scissors before opening the choroid all around. You're going to use the sclera as a handle, and then you open the choroid, and you don't touch the choroid after that. You just use the blunt scissor and go around the tumor in the healthy choroid with a safety margin of 1.5 to 2 millimeters around the tumor until you get the tumor out of the eye. This is the tumor, as you can see. At this point, you get, of course, hypotony, and in order to reduce the incidence of detachment, sometimes we do a limited vitrectomy to reduce the intraocular pressure to minimize prolapse of the ocular tissue outside of this large defect. At the end of surgery, finally you close the lamellar scleral flap and put a plaque over the tumor to reduce the incidence of any recurrence. I have been following this patient now maybe for 5 or 6 years, and although she developed a detachment and I operated it 1 month later, but still she has a vision of 0.2. Now coming to another form of external resection for anterior tumors, which is anterior ciliary body and iris tumors. And this patient presented in 2013 with an iridociliary mass on routine examination, distorting the pupil and occupying the angle of the anterior chamber. The UBM confirmed that this mass is a melanoma invading the angle of the anterior chamber and originating in the ciliary body. So I decided to do an iridocyclectomy and application of a ruthenium plaque. So this is the surgery, as you can see. The pupil is dilated. Again, you localize the tumor by transillumination, go outside the tumor by 1.5 millimeter on either side, and then you do a large scleral flap as we do in glaucoma surgery. This is a half thickness scleral flap. Start your dissection anteriorly until you reach to the anterior chamber, slowly, step by step, until you reach to the anterior part and get into clear cornea. Next, I do 2 incisions using the MVR on either side. I exteriorize the iris completely and do a radial cut in the iris on either side to cut the tumor from both sides, and then continue opening my incision. Of course, I fill the anterior chamber with healing at this point, and then start cutting a full thickness sclerocyclectomy, getting the tumor out of the eye. Of course, you will get vitreous at this point because you are removing completely the ciliary body. And I have some hyphema in the anterior chamber, which was cleared by injecting viscoelastic. And finally, the scleral flap was closed using interrupted 6-0 vicryl sutures. And finally, a ruthenium plaque was placed on the base. You can see putting the ruthenium plaque at the end to irradiate the base of the tumor. And I followed up this patient. This is the UBM for 5 years. And he developed cataract, a subluxated lens, and a large iris defect. And the UBM showed no recurrence. So at this point, I decided to do him an iris to correct him and do هو الفيديو ده مش شغال ليه؟ اوكي ماشي خلاص. Do him the cataract surgery and implant him even with an artificial iris. You can see the subluxated lens in this part where the tumor was resected, and doing the phacosurgery, which was not difficult. And finally putting 2 capsular tension rings to stabilize the capsular bag. Oh, sorry, the video. Can we, okay, start the video, and I will just advance this to show you. After putting the intraocular lens, I put him an iris prosthesis, which is that of human optics, to reconstruct the iris defect. And the iris prosthesis was implanted inside the eye. It is unfolded. This is on the left side. You can see the natural iris of the patient. It has, oh, sorry, again. This is the natural iris of the patient on this side. And the lighter color is that of the artificial iris. It is put behind the natural iris of the lens in the posterior chamber. This is the reconstruction process. And he had a best corrected vision of 0.3 with a mild PCO pending for capsulotomy. Now moving to endoresection, this is indicated for posterior tumors with a narrow base, too high to be treated with a pluck. And after gamma knife, because when we do gamma knife and leave the patient without resection, they develop what we call the toxic tumor syndrome. They develop prolonged intraocular inflammation, and finally they get rubiosis iridis, neovascular glaucoma, and end with a blind, painful eye after 1 to 2 years. So usually we like to remove the tumor after gamma knife. And those tumors associated with vitreous hemorrhage. The idea is to remove the tumor by piecemeal using the vitreous cutter after gamma knife irradiation and placing a plaque on the base at the end of surgery. Again, this is one of the cases for endoresection. And you can see the tumor. It has been irradiated with gamma knife the week earlier, inducing the posterior vitreous detachment. And in doing the core vitrectomy, making sure that the posterior hyaloid and the peripheral vitreous has been shaved properly before attacking the tumor, finally injecting PFC over the macula, and doing endodiathermy to the larger vessels over the tumor, and then you start cutting full thickness retina and the tumor at the same time until you reach the white sclera at the base. This is continued, and at this point you have to be having hypotensive anesthesia, and you have to be very quick and raising the intraocular pressure to minimize bleeding from the choroid. This is continued until you remove the tumor completely, and then you do endolaser. You complete your perfluorocarbon fill. You do your endolaser to the margin of the tumor, and finally you do a direct PFC silicone oil exchange. And this is very important to avoid air embolism, which can be fatal in these cases. Thank you very much.
And the diagnosis was really challenging, although clinically, and Dr. Hani even was very confident it is a retinoblastoma. We had to take an aspirate, and a fine needle aspirate from the anterior chamber, and send it for cytology, and we injected also melphalan in the same setting, and the dramatic response to the chemotherapy for this case, for example, was surely diagnostic. The second day, the seeds completely disappeared with the iris nodules, and the cytology was even positive, and we resorted to enucleation in this case. But sometimes the management is challenging in the absence of evident calcifications. But these are this is not the rule. The rule is the presence of calcifications.
Any other questions from the, yes?
Thank you for this very nice session. I am Dr. Babikr Kandau from Sudan. Also, a question to Dr. Dina. If or retinoblastoma is unilateral, what do you do for the follow eye, and what is the regime for the follow-up?
With the initial diagnosis, we have to do a dilated fundus examination with indentation of the fellow eye, and the ultrasound is also done concurrently on the other eye. And we have to follow with each follow-up of the eye treated, we have to also examine the fellow eye. And it has to be followed up in every follow-up visit, every 2 to 3 months within the first year, every 3 to 4 months in the second year, and then up to school age every 6 months and to 1 year. So the fellow eye has to be examined, especially in cases who presented very early or with multifocality and, or of course, familial cases, because these cases are the hereditary cases with bilaterality incidence very high.
If I may add that in hereditary retinoblastoma, you have to examine also the sisters and brothers of the patient. This is very important to counsel the family, and you may find tumors also in these cases. You continue follow-up until at least the age of 6 to 7 years, because the retinal cells are still immature and may develop new tumors. So this is very important, as Dr. Dina said, and indentation is important because the peripheral retinal cells are more immature, and you are more likely to find peripheral tumors than posterior tumors in these cases. Any other questions? Yes?
I'm Dr. Rakesh Shakia from India. My question to Dr. Hani, what are the incidence of glaucoma and when you put the artificial iris? So there is any role of peripheral adectomy?
Usually, I mean, you size this artificial iris 1 millimeter less than the white to white. You have to measure the white to white by biomicroscopy, and you do actually an iridectomy in this to prevent pupillary block. And these are also, I mean, this is very important. Before you use the iris of human optics, you have to take a course online to know how to use it, how to measure it, and how to do an iridectomy to avoid complications. And they do not even sell it except if you get certified in this course, so that you know the guidelines. If you don't respect these guidelines, you will definitely get glaucoma and have to remove it. And this is different from the artificial iris that is used to change the color of the iris. And this is put in the posterior chamber, not in the anterior chamber, and sometimes you can put it even in the capsule of the lens if you have an intact capsular bag.
Thank you.
Any other questions? I guess this concludes this session, and we move to the next session by the Egyptian Vitreoretinal Society. May I invite the president of our society, Professor Khaled Rakhawi, to